So, very good morning, everyone. And at the outset, I would like to thank Professor Amit Goel, sir, and the Department of Hepatology for this kind invitation. And I have been assigned the topic of methods for the assessment of liver fibrosis. So, without wasting much time, I'll start with the first slide. So, if you want to assess fibrosis in a patient, there are two basic different category of methods. The first one is invasive liver biopsy, and the second group is non-invasive methods. In non-invasive methods, you can have serum biomarkers, or you can have radiological or physical property-based tests. So just a brief overview of the methods. You can have liver biopsy, which is an invasive method. You can have imaging, simple imaging like ultrasound, CT scan. You can have biomarkers. In biomarkers, you have two different types of biomarkers, indirect biomarkers and direct biomarkers. And then there are certain commercially available combination tests and also the formulas, online calculator formulas, depending on various direct and indirect biomarkers. So what are these indirect markers? If you have a patient in whom you are suspecting significant fibrosis or cirrhosis, you order certain basic tests like CBC, LFT, and INR. If the platelet is on the lower side, there is AST, ALT reversal. INR is on a higher side. This gives an indication that the patient has a significant fibrosis or cirrhosis. So these are indirect markers. In direct markers, you have markers which suggest that the collagen is being formed or it is being degraded. And depending on that, you have different kind of direct markers like type 3 procollagen, type 4 collagen, tissue inhibitor of matrix metalloproteinases, and other factors like transforming growth factor beta. Liver biopsy, we have already seen in the previous talk in great detail. For us, the very clinically relevant classification for liver biopsy is a METAVER score, which is simple and very clinically relevant. In combination biomarkers, you have different tests, as you can see, APRI, FIF4, ELF score, and a lot of them. But for us, the relevant ones in the clinical practice are APRI and FIF4, and sometimes ELF score. So we'll see this in detail in subsequent slides. So in any scenario, the gold standard for diagnosis of cirrhosis or liver fibrosis is liver biopsy. And how to classify, how to grade the degree of fibrosis, we have already seen in the previous talk. So I'll not go into detail, but I heard a question that how commonly we perform liver biopsy. So in cirrhotics, obviously we don't perform liver biopsy because we know it is a burnt out disease and it would hardly make a difference. And second point is, it is an invasive test which has a risk of complications. Pain is very common, and a lot of these patients will have thrombocytopenia, coagulopathy. So there is risk of bleeding, there is risk of infection, there is risk of perforation, and sometimes even the risk of death because of excessive bleeding in patients with liver biopsy. The second point of view is the quality of the specimen when we take liver biopsy is also very, very important. So it has to be a good size sample, and it has to be read by a very good and experienced pathologist because it is observer dependent. So these are certain limitations of liver biopsy. Histologic grading we have already seen in detail. For us, the METAVER score is very important because F0 and F1 are like no or minimal fibrosis. F2, F3 are good moderate amount of fibrosis. And F4 is the end stage fibrosis, what we call as cirrhosis. So in non-invasive assessment, we have indirect markers. Indirect markers, they reflect hepatic injury or the complications of portal hypertension like platelet count, INR, AST, ALT. Indirect markers, these are the markers of extracellular matrix degradation or fibrogenesis. So direct markers can be of linked to matrix deposition like procollagen, hyaluronic acid, laminin, etc. Direct markers linked to matrix degradation are MMPs. So I think someone asked a question in the previous talk that what is the mechanism in which the fibrosis can be reversed? So the classical concept is that cirrhosis cannot be reversed, but fibrosis is partially reversible. And sometimes in earlier stages, it can be reversed even completely if the etiology has been cured, like in hepatitis C. So what is the mechanism in which the fibrosis is reversed? This is the answer. So these are the enzymes known as matrix metalloproteinases, also known as collagenases. So they have the ability and capacity to dissolve and degrade collagen and reverse the fibrosis. So this is the answer. So there are various scoring systems for liver fibrosis with different sensitivity and specificity. I'll just talk about the clinically relevant ones. So the most clinically relevant and the easiest to be done is APRI score, which utilizes only AST and platelet count. Second one is FIB-4, which utilizes platelet count, AST, ALT, and age. And then there are certain scores which are based on direct biomarkers, of which we have ELF score, FibroSpect, and a lot of them, but ELF score and FibroSpect 2 are the most studied ones. We'll see a few of them in detail in subsequent slides. So APRI. APRI is based on a concept of that if there is cirrhosis, there is diminished clearance of AST and also thrombocytopenia. So if you want to calculate APRI, this is the formula. AST upon AST of upper limit of normal of AST divided by platelet count into 100. So if you are sitting in a, say, in a peripheral primary care setting, and if you have a patient, these days everyone has access to CBC and platelet count and LFT, AST. So everyone has a multimedia phone and access to internet. There are online calculators available. You just need to put these values of AST and platelet count into the formula, and within seconds you will have a APRI value. So it is very useful for excluding significant fibrosis. It's very simple, easy to perform even in primary care settings, and does not require any specific biomarker. So if you see, this was a very good meta-analysis regarding the performance of APRI as a marker of advanced fibrosis or cirrhosis. So for cirrhosis, the area under the curve is 0.83 for a APRI cutoff of 1 with a sensitivity and a specificity of more than 70%. So just for those who are not aware what is area under curve. So this is a curve of sensitivity on y-axis and 1 minus specificity on x-axis. So if area under curve is 0.5, that means the test is as good as a random guessing. And any score which is more than 0.5 or 50% and 1, between 0.5 and 1 it is better than random guessing. So 1 would be a very ideal test. So any area under curve of more than 80 is considered as a good test. So APRI with a cutoff of 1 has a sensitivity specificity of 70% and area under curve of more than 80%. So it is a good test, especially in a resource limited setting. The second index, which is also based on indirect markers, is FIB-4. We need to have platelet count, ALT, AST, and age. There are online calculators available for this also. You just need to put these values in a formula and then you will have a value. So there are different cutoffs for different etiologies. What blanket cutoff, if you want to take one cutoff for F3, F4 fibrosis, anything more than 3.25 APRI FIB-4 score gives you an indication of advanced fibrosis or cirrhosis. So this was a study which compared the accuracy of FIB-4 as a biomarker for fibrosis in hepatitis C patients in comparison with liver biopsy. And as you can see, the area under curve for diagnosis of cirrhosis, FIB-4 performed very good with an area of under curve of 0.91. And the cutoff value of more than 3.5 would have a positive predictive value of more than 80% for F3 and F4 fibrosis. So it is also a good marker. Now, ELF score is just a score for direct biomarkers, which includes hyaluronic acid, tissue inhibitor of matrix metalloproteinase 1, amino-terminal peptide for procollagen type 3. As in the previous talk, we have already heard that the type 3 procollagen is also one of the type of collagen which is deposited in the periportal areas. Then there is a very complicated formula, and then you have a score. Any score of more than 10.3 would suggest F4 fibrosis. So if you ask me in clinical practice, neither me or nor of any of my close colleagues have ever ordered this test for the diagnosis of F4 fibrosis. And somehow I don't know why even there is no push by pharmaceutical or lab test. So while making this presentation, I was curious enough to know whether this is available or not. So this is being done in some private labs in Lucknow, and the cost of the test is around 5,000 rupees, and which is the cost of fibroscan test, which is much validated in a corporate hospital, in a good corporate hospital. So anybody would like to go for a fibroscan test, which is even more widely available and of the same cost rather than this test. Is immediately available. And it is portable, can be done anywhere. Report is available, and not only fibrosis, you can have a marker of steatosis also in that. And it is much validated for even for the staging of cirrhosis also. Well, we'll see in subsequent slides. So that's why utility of such scoring system utilizing direct biomarkers is very, very limited in routine clinical practice. However, if you see the data, this is a meta-analysis of 9 studies in which it concluded that it shows ELF score shows good performance and considerable diagnostic value for prediction of histologic fibrosis in patients. So next category is tests which are based on physical property. So physical property based test, you have transient elastography, what we know as fibroscan by EcoSense. Then there are certain tests which are based on routine ultrasound machines. They use the property of shear wave elastography. So point shear wave elastography is RFE, acoustic radiation force impulse. And these days, some latest softwares are available which calculate two-dimensional shear wave elastography. Not readily available everywhere. And the third one is which uses MRI as a measurement of elastography, what we know as MRE or magnetic resonance in elastography. So these 3 category of tests are available, which are dependent on the physical property of the liver parenchyma. Of all these tests, transient elastography by fibroscan is most extensively studied, and it is most validated imaging technique with high intra and inter-observer reproducibility. It is done by a very simple portable machine, so now it can be carried anywhere, and not only assessment of fibrosis in the form of liver stiffness measurement or LSM, it also measures control attenuation parameter or CAP, which gives you a gradation of steatosis, which is a pre-fibrotic state. And it was first approved by FDA in 2013. And since then, a lot of studies have been done, and it has been extensively validated in different patient populations. So this was a meta-analysis for assessment of performance of transient elastography for staging of liver fibrosis. And if you see, the conclusion was it can be performed with excellent diagnostic accuracy. And if you see the area under curve in this meta-analysis, for the diagnosis of cirrhosis, the area under curve was 0.9%, which comes under the category of excellent diagnostic test for cirrhosis. So it is a very good test for ruling out or even ruling in cirrhosis. So this is how it is done. There is a very simple machine with a probe and a screen. The patient lies down in supine position with the right arm behind his head. Then you draw a straight line from Xiphi sternum to the intercostal space, and then you apply this probe and you fire. Then you have 2 kinds of values on this screen. As you can see, there are true values. This value is known as LSM or liver stiffness measurement, and this is CAP or control attenuation parameter. So it gives you 2 different values. Stiffness is a marker of fibrosis, and CAP is a marker of steatosis. And it explores around 3 centimeter cube area, which is at least 100 times more than that of a liver biopsy. So what are different cutoffs? So if you see the studies of fibroscan, a value of more than 12.5 would be suggestive of F4 fibrosis in most of the etiologies. And a value of less than 7 is suggestive of a normal liver. So anything between 7 and 12.5 is like significant or severe fibrosis. So this is a slide from Baveno 7 consensus. So not only the gradation and of the fibrosis according to the meta scoring system, but this can also be used to define some of the concepts of and staging of the chronic cirrhosis. Like anything more than 15 kPa on LSM would be assumed as a compensated advanced chronic liver disease. and more than 25 kPa or between 20 to 25 kPa and platelet count of less than 1.5 lakh would be suggestive of CSPH, what we call as clinically significant portal hypertension. That means varices can be present in such a patient. So its utility goes beyond the simple measurement of fibrosis and steatosis. It can also be used in grading and staging of the liver injury or cirrhosis. The second indirect test is RFE, acoustic radiation force impulse. So it is done by the ultrasonologist. It is done by the simple ultrasound machine. And there are two very basic advantages of RFE, that it can be done in patients with ascites and also in patients with obesity. Because here, under real-time ultrasound guidance, you can mark an area where liver stiffness can be measured. So there is no interface between the probe and the liver capsule, like in FibroScan. So FibroScan has limited utility in very obese patients and also in patients who have ascites. A lot of these patients will have ascites if they have a decompensated cirrhosis. In such scenarios, there is use of RFE, and it utilizes the concept of shear wave elastography. So if you see, it measures the speed, velocity, and anything more than 1.8 meter per second is suggestive of F4 fibrosis. So these are three basic tests: transient elastography, acoustic radiation force impulse or RFE, and 2D shear wave elastography or 2D SWE. And accuracy and area under the curve is maximum for transient elastography. And the advantage of RFE is that it can be applied in patients with obesity and or ascites also. This has very limited availability. And at the last, we'll discuss about MR elastography. So it predicts the fibrosis very effectively in patients of chronic liver disease, producing a wider and more representative map of the liver stiffness. So it can measure the stiffness of liver not only of small area, say 3 centimeter cube or a 2 centimeter cube, but of liver as a whole. And its principle is similar of transient elastography. For cirrhosis, the area under curve is 0.94. So the performance as a diagnostic test for diagnosis of cirrhosis for MR elastography is excellent. And as you can see, it measures the stiffness in kilopascals. And anything more than 3.77 is suggestive of F3. And more than 4.09 is suggestive of F4 fibrosis. So if I ask you that which test is the best test amongst all the non-invasive tests for assessment of liver fibrosis, the best performance is of MR elastography. But it has two very big disadvantages: costly, not easily available, and unlike very small team like you, which showed in biopsy-proven NAFLD patients, and it has suggested that the performance of MR elastography versus transient elastography in all stages of fibrosis, the performance of MRE is better than transient elastography. As you can see in the last graph, the MR elastography has more than 93%, and the FibroScan has around more than 80% area under the 0.005. So the performance of MRE is better than TE in this meta-analysis and also in real-world settings. So I would like to conclude that liver biopsy, although it remains the gold standard, utility of direct biomarkers is very, very limited in routine clinical practice. Scores of indirect markers like APRI and FIB4 are very instrumental, particularly in resource-constrained settings. And we were discussing about the National Viral Hepatitis Control Program. So if you see the basic slides of assessment of fibrosis in hepatitis C patients, which are provided for teaching and training purposes in the National Viral Hepatitis Control Program, they focus on only three things: APRI, FIB4, and FibroScan. So if you are sitting at a tertiary center where FibroScan is available, use FibroScan. But if you are sitting in a peripheral center where only CBC and LFT are available, you can use APRI and FIB4, and they are also very good markers. So they are very clinically relevant. FibroScan is the most validated and the simplest test available. It can be easily done with a small portable machine. And in addition to fibrosis, it can also tell us about the gradation of steatosis and also in classifying and staging the liver cirrhosis. Of all the non-invasive tests, MR elastography performs the best, but has limited availability, and it is of a high cost and requires expertise of a radiologist. So with this, I end my presentation. Thank you for your patient listening.